Good afternoon. Thank you for attending our MIT virtual conference. Today, I'm going to present a project that demonstrates the use of modeling and simulation tools to quantitatively assess the QTc interval prolongation risk of a drug. This particular example was the analysis was conducted in phase 3 stage, but according to the Concentration-QTc white paper, with the right study design and appropriate analysis method, conducting this type of concentration-QTc modeling in early phase 1 can exclude clinical relevant QTc effects for some drugs so that a thorough QT study can be avoided. A little background on the drug. Quizartinib is a type 2 FLT3 ITD inhibitor. The FMS-related tyrosine kinase 3 mutation was found in approximately 30% of patients with acute myeloid leukemia. And within the FLT3 mutations, the internal tandem duplication is associated with high relapse rates and decreased response to salvage therapy. Based on a separate efficacy analysis of this phase 3 study, it's found that when treated with quizartinib, patients with relapsed or refractory acute myeloid leukemia increase in overall survival, as well as decrease in the risk of death by 24%. However, dose-dependent QT prolongation is a major adverse event associated with quizartinib. The objective of this study is to, in addition to build a population PK model, is to quantify the relationship between quizartinib concentration and the QTc effect. But for this presentation, I'll focus on the concentration QTc effect of the analysis. So a little bit background on the data that's used, that's collected in the phase 3 study that's called QuANTUM-R. This study started with 30 milligrams of quizartinib per because strong CYP3A inhibitor was known to increase the exposure of quizartinib. During the study, there were several assessment points where dose adjustment was allowed based on assessment of certain safety and efficacy criteria. And the dose adjustment included dose increase and dose reduction. The ECG samples that were used in this analysis was centrally read triplicate QTc measures, including pre-dose, 2, 4, and 6 hours post-dose on extensive PK sampling days and some other sparse samples. And the QT was corrected using the Federicia's equation, QTCF. For this concentration QTc analysis, the PK samples were limited to those that were time matched with ECG measurement. To determine the structural model, various functional forms were evaluated, including a linear functional form, a linear model with separate slopes representing quizartinib and metabolite AC886 concentration separately, and then maximum effect model or Emax model with separate Emax function representing the effects of quizartinib and AC886. Model selection was based on typical criteria, including objective function evaluation, inspection of goodness of fit plots, decrease in inter-individual variability estimates, and or residual variability estimates. The model was developed using first-order conditional estimation method with interaction and NAMM. So there were a total of 2,842 time-matched concentration and QTc samples from 226 patients that were used in this analysis. When we performed the time matching, the actual time of PK concentration and the ECG measurements were compared. If the differences between them were less than 30 minutes, then the match was made. Otherwise, we exclude the observation. For 24-hour samples, we expand the matching window to 90 minutes to allow for more possible time matched samples. The table on the right summarizes the patient characteristics of the covariates that were tested in the analysis. There were slightly more women than men in the study, with majority of white patients. There were also a fair amount of patients with electrolyte deficiencies. This is a plot of mean and standard deviation of the observed QTCF change from baseline, plotted against the time duration, throughout the study. As you can see, starting day 8 in cycle 1, the average delta QTCF starting to exceed 10 milliseconds. So this is a drug that causes quite significant QT prolongation. So based on the exploratory data analysis and model selection criteria, the evaluation supported an Emax model to describe the relationship between quizartinib and ACA86 concentration and QTC effect. There were two separate Emax functions in the equation describing the effects of quizartinib and ACA86 separately. The base model also included a baseline term to estimate the typical value of baseline QTCF. To account for the circadian rhythm, the time effect was estimated in the model. The baseline QTCF data was split into 10 bins based on clock time of the QTC measurement, with approximately the same number of samples in each bin. And the mean time effect on QTCF for the 10 bins were estimated by the model. Based on the parameter estimate, the effect of quizartinib on QTCF is approximately 12 times of the effect of the metabolite ACA86. With the covariate analysis, hypokalemia was found to be a statistically significant predictor of the baseline QTCF, but not a statistically significant predictor of the maximum effect caused by the concentration. In patients with hypokalemia, their baseline QTCF was predicted to be 6.15 milliseconds longer than the population mean. This is a plot of the observed delta QTCF plotted against quizartinib concentration. Different colors denote different doses of quizartinib. As you can see, delta Q with the data had a large variability. However, as the concentration increases, there's an increasing trend of delta QTCF. The black line and the shaded area going through the middle of the data represent the model predicted mean delta QTCF at 90% confidence interval. As you can see, the model corresponds well with the observed data in describing the trend and the shape of delta QTC increase. To understand the clinical relevance of QT prolongation, the final model was used to predict the mean delta QTCF and 90% confidence interval at steady state Cmax, steady state maximum concentration following various dosing scenarios. These dosing scenarios included hypothetical scenarios of patients following 30 or 60 milligram daily dosing corresponding to the first and the third lines in the table, and actual patients that followed the highest dosing regimen throughout the study, which is 60 milligram daily dosing of quizartinib, listed in the second line of the table. So as we can see here, as doses goes up, the change in QTCF increases. Unfortunately, they're all above the threshold of 10 millisecond per of regulatory concern.
Anna, just to let you know, you have about 2 minutes left in the session.
Yes, almost. From this modeling and simulation activity, we were able to conclude that the QTCF increases with the increase of concentration of both quizartinib and metabolite AC886, and none of the covariates evaluated was identified as having statistically significant effect on the concentration-QTc relationship. So that was the end. Is there any questions?
Thank you, Hannah, for the presentation. If anybody would like to send in any questions via chat or the Q&A, please go ahead. Okay, I'll jump in here, Hannah. What would be the limitation of this type of concentration QTc model?
Okay, first of all, this type of model cannot be used in anti-arrhythmic drugs because those were supposed to affect heart rate by nature and QTCF by nature. And there are also 4 assumptions that you have to meet before you can apply this type of predefined model. So including there's no drug-induced increase in heart rate for more than average of 10 beats per minute, no hysteresis. It has to be a direct effect model, and then there's a linear relationship between the concentration and effect model, but of course, alternative shapes can be explored. Yeah, so there were 4 assumptions that has to be met before you can apply this type of models.
Okay, thank you.
And of course, we have checked all 4 of them and they all were satisfied.